first. I'll briefly talk about IPC. Introduction, permission, position for CVS is supine position 45 degrees. Then exposure, undress till the waist. Then comfortable. Then proceed to general inspection. The way I remember the general inspection is PCLC Ma is a PR in H&G company. So I treat PCLC as a name lah. Then Ma is a Chinese surname. So PCLC is position, comfortable, look, and consciousness. Then PR is pain and respiratory distress. There are 6 features of respiratory distress, and I remember it as not calm. NOT-CALM. So for NO is nose lah, flaring of the wing of nose. Then tachypnea for T, more than 20 per minute. C, cyanosis. A, accessories muscle. Then L, lips, or pursed lips. Then M is muscle retraction. Then for H and G is hydrational status, nutritional status, and gross deformity. Then MA is movement and attachment. So now I like a volunteer, a guy, to be my patient. For general examination of CVS. Hey, 45 degrees. 45.
Assume 45 吗？
So the sequence is we check for upper limb first, then neck, head, lower limb, then only chest. So we start off with upper limb from distal to proximal, check for palm, finger, radial pulse, then DP. So for palm, we check 2 hands together, MTC, moisture, temperature, and color. So temperature, feel like this. It should be on the bed actually. So like this. Then for finger, we check for 3 C's, cyanosis, capillary feeling, and clubbing. So for capillary feeling, just press on the left plate, then normal is less than 2 seconds. So for clubbing, first we see the angle of the nail bed and the cuticle. For nail clubbing, it's more than 180 degrees. Then second test is we call Scamrod's window test. So we ask the patient to do like this. So normal, we will see a lozenge-shaped gap between the thumbs. It's a window lah. Then for third test is called Fluctuation Test. So we use two hands, 2 index finger near the DIP joint, like this. Then 2 thumbs under the finger pad. So basically we just move around like that. So if there is nail clubbing, we'll feel that there is spongy feeling, or the other word is ballotable at the cuticle, if there is clubbing. So then we check for radial pulse. Simultaneously check whether it's symmetrical or not. Then we calculate the rate, and we see the rhythm, whether it's regular or irregular. For regular pulse, we check for 15 seconds. For irregular, check for 30 seconds. We check the radial pulse like this, right? Then we ask the patient to put his hand on the chest. Then we check for respiratory rate. Then for collapsing pulse, we change the other hand. Just now we used his hand, right? Then we locate the radial pulse again. Then wrap our palms around the wrist, support the hand. Then we raise the hand above the patient's head. If the patient has collapsing pulse, we'll feel the pulse is knocking on our palm. It's like like this. Then we check for BP. Have to remember the BP the cuff has to be placed at the heart level, 2 fingers above the cubital fossa, and we should be able to insert 2 fingers into the cuff. Then we inflate the cuff while we are palpating the. Then we inflate the cuff. Then we palpate the radial artery. Then when the radial artery disappears, we inflate 20 to 30 mm mercury more. Then we only auscultate and see the BP. Okay, then we proceed to neck region. For neck region, we have to find a JVP. Am I too fast? Okay. So we see the JVP. We ask the patient to turn his head away from the midline to the left side. Then we locate the pulsation. So when we see the pulsation, we have to differentiate the jugular pulse and the carotid pulse. So we have to do 4 things. First is we palpate the pulse. We palpate the pulse. The jugular pulse is visible but not palpable. Then we obliterate. The second step we have to do is we obliterate the jugular pulse. We obliterate the vein like this. Then we release the upper finger. Then the vein filling should be from above to below. If it's the other way around, it's the carotid artery, it's not the jugular vein. Then third one is we ask the patient to do deep inspiration, and the pulse should be decreased. Then the next one is, the 4th step is we do the hepatojugular reflex. We press below the costal arch, the right costal arch. Press, then we'll see the pulse is increased. Then we proceed to the head region. So first we see the face first to see whether the patient has malar flush. Then we have to find 2 important signs, the jaundice and anemia. For jaundice, we look at the sclera and the frenulum of the tongue. Then for anemia, we see conjunctiva. So we ask the patient to look at our finger and follow my finger movement. Look down and okay, then look up. So from this one, we can see the sclera and conjunctiva together. This, okay. Then we see the tongue, whether it is coated or not. Then you flip it upwards to see the frenulum. Then for lower extremity, okay, we test for edema first. Have to press on the tibial prominence. Press for a few seconds. Then for peripheral pulse, start from femoral to distal part. Femoral artery, we have to know the exact location. We have to know how to describe the location of the pulse. So the femoral artery is the midpoint of the line between the superior border of pubic symphysis and the anterior superior iliac spine. So it's the midpoint. Then we palpate simultaneously. Then popliteal artery. This one we have to do one by one. So we put the 2 thumbs onto the patella, other finger wrap around the leg. Then we press the popliteal fossa. Press it again upwards, upwards to feel the popliteal artery. So do one, then do the other one. So when you are doing the popliteal artery, the patient is like this, right? You ask him to flex a bit. If you still cannot palpate, then you lift up a bit. But don't ask the patient to flex the leg more, because if the muscle is tense, you cannot feel anything. So you lift up a bit passively. Then the dorsalis, the location is between the first and the second metatarsal bone, and you press on the tarsal prominence tarsal bone. So it's like this, right? Between, and you press on the tarsal bone prominence. So we do together. Then for tibial, posterior tibial artery, we find the medial malleolus, then it's below and posterior to the medial malleolus.